Good morning, everybody. Today, in honor of National Stroke Awareness Month, I wanted to put out a quick talk, educational piece on recognizing stroke. And I think recognizing stroke is pretty easy. I think most of us can understand and realize, hey, this seems like it may be a stroke. But do you need to activate it as a code stroke or a code angio? And I think sometimes that can become a little bit confusing because for some folks it might be very easy and very clear, but for others they have a very long-winded story on when everything started and it's not so clear-cut. So I wanted to just go through a couple of scenarios, and this is going to be interactive, guys, okay, so I'll need your help, help wake you up this morning. But we'll run through a couple of quick scenarios and hopefully it'll give you some examples on helping you figure out, is this a code stroke or not. I thought of just about every kind of example I could think of. So hopefully this will cover almost every scenario you could have on whether you need to call it a code stroke or not, okay? Now there's two things, now we are doing code strokes in which patients are given TPA, but now there's also code angio in which both of the hospitals here in Tyler, they also do neurointervention, and there's different time frames for both, which I'll go over very quickly. So how important is stroke? Well, between 2014 and 2016, the death rate of stroke patients that were 65 years and older, you can see in East Texas, the darker the purple, the worse our death rates are. So in East Texas, you can see we're not doing so good. There's a lot of people dying from strokes here in East Texas. So it's a pretty big deal. The numbers over here, I don't know if you can see them, but you're talking between 300 to 770 patients a year out of 100,000 that are dying every year from stroke. So pretty big deal here in East Texas. So TPA candidates, and this is just kind of a quick review. TPA candidates, a candidate for TPA is a person that's a suspected diagnosis of ischemic stroke. They have a measurable deficit, they get obvious facial droop and one-sided weakness or speech deficit or something else that is very obvious, and onset of symptoms less than 4.5 hours, okay? 3 hours is the only time frame that's applicable to some patients, but some patients they can get TPA up to 4.5 hours. If they're within 4.5 hours, we should just activate it and let the hospital figure out, okay, does this person fall for the 4.5 window or not? Okay, so the very important part here, the time of onset, that's the part where sometimes it can get confusing, but the time of onset is defined as the last time the patient was known to be normal. Not when the patient thinks the symptoms started, not when the family found the patient like this, the last time they were seen normal. There could be people that last time they were seen normal was yesterday, and that's what you have to go by, because this is a very dangerous thing that you're giving to a person, and if you don't have the timing right, you can completely devastate a person. So it's very important, and you have to be very conservative as far as last time the patient was seen normal. It's important to get an actual time and not just how many hours it has been, because a lot of times people tell you, well, I think it's probably been about an hour. No, when was the time? When was the last time you actually remember looking at the clock and you knew, okay, this was, because a lot of times it's very inaccurate when people think it's been an hour, it's probably been a lot longer. So you want to try to pin them down to an actual time if you can, okay? Angio candidates, so TPA is 4.5 hours, but candidates for angio are up to 24 hours after onset, regardless of if they got TPA or not. So even if you have a patient, their symptoms have been going on for over 6 hours, there might still be a candidate for angio intervention. So make sure you recognize that and you still activate it as a stroke, because even though the patient may not get TPA, you still want to rush them to CT, you still want to rush them to get everything done. That way they can figure out, can we do any kind of neurointervention on these patients or not? So scenario number one, so if you've got a patient who's been normal all day, he had lunch with his wife, at 1300, the patient developed slurred speech, left arm, leg weakness, and numbness, okay? You guys get there at 1:30. Are you gonna activate this as a code stroke TPA candidate?
Yes.
Absolutely, right? time of onset is 1300, you know an exact time, you're there within 30 minutes, and you still have, 4 hours to go. But, and remember, the sooner the TPA is given, the better. So just because you have a 3-hour window or sometimes a 4.5-hour window, you don't want to wait till that last minute. You want to get it started as soon as possible, okay? So very simple, right? Let's get a little bit more complex here. You got a patient, he's been normal all day, ate lunch with his wife at 1300. He went to take a nap while the wife went to the grocery store. He woke up at 1500, and the wife got back at 1700 and noted the patient had slurred speech and left arm leg weakness. So what is your time of onset on this patient?
1300.
1300, right? 1300. Is he a TPA candidate?
For 30 minutes.
For 30, that's exactly right. Exactly right. So time of onset is 1 p.m. That's the last time anybody saw him normal, okay? We don't know if he had symptoms when he woke up at 1500 or if they started in between 1500 after he woke up and 1700. You don't know, so you have to go with 1300. And you have 30 minutes for a TPA window, and that's if he falls into the 4.5-hour category. There's certain things, once you're past a certain age, if you're diabetic, there's certain criteria that limit you from being in the 4.5-hour TPA window. But that's like, we can let the doctor figure that out. We want to give him every opportunity possible. So 30 minutes. So scenario number 3. And I apologize, guys. A lot of these scenarios are all going to wife at 1 o'clock. He went to take a nap. Wife went to the grocery store. He woke up at 3 o'clock. He went outside, spoke with the neighbor at 4 p.m. And the neighbor's there. He said, yeah, he was normal. He was moving everything, talking normal. When the wife gets back at 5, she notes he's got slurred speech and his left arm and leg are weak. So what's your time of onset here? 1600, right? Somebody saw him normal. So time of onset is 1600. He was seen normal by the neighbor who confirms it. This is a TPA candidate, okay? Scenario number 4. Patient's normal all day. This guy's eating a lot of lunch here, but he eats lunch at 1 o'clock. He goes to take a nap. Wife goes to the grocery store. He wakes up at 3 o'clock. He spoke to his daughter at 4 o'clock on the phone, who reports he was talking normally and they had a normal conversation. The wife gets back at 5, notes the patient's got slurred speech, left arm, leg weakness. What's your time of onset? 1300?
1600?
1600. So this is where it gets confusing, right? Either or, okay? So this is one of those things where you want to, it's open interpretation. It could be 1600. He had a normal conversation and now he's got slurred speech, and the daughter confirms, no, he was talking completely normal. He was not talking slurred like this, but he wasn't seen in person. So it's kind of hard to tell. It could be considered 1300 because that was the actual last time that he was actually seen functioning normally. So in this scenario, there's kind of a confusing picture here. You want to activate it because if the onset is considered 1600, only an hour has passed, you still have a really big window. If you get to the hospital and the ER doc talks to the neurologist and they're like, well, do we want to use 1300 because that was the actual last time seen? You still got a 30-minute TPA window, so you still want to go ahead and activate this, but you want to activate it as 1600, but he wasn't seen normal until 1 o'clock, and just let the ER know about that when you get there. But that's a call that they'd have to make in discussion with the neurologist and based on how severe are his deficits, and do you want to go with 1600, or 1300 as the time of onset. So you got a patient normal all day, goes to sleep at 10 p.m. with his wife, who reports everything was normal. They wake up at 6 a.m. and the patient has left-sided weakness. What's your time of onset? 2200. TPA candidate? Not at all. Way out of the window, but is an Angio candidate, right? So that's something to remember. Scenario number 6, normal all day, takes a nap at 1 p.m., everything is normal. Wakes up at 2:30, left-sided weakness and slurred speech. What's your time of onset? 1300. TPA candidate? Absolutely. So the point of this one, this seems very obvious here, time of onset is 1300, still a candidate for TPA. So the one thing that I want to make sure that we understand is just because you wake up with stroke symptoms, it does not rule out TPA candidacy. If they went to sleep and less than 4.5 hours has passed by and they were normal before they went to sleep, they are still a TPA candidate. Okay, so you can wake up with a stroke. If it's been less than 4.5 hours, you can still get it. So wake up stroke does not equal not TPA candidate. Scenario number 7. Patient gets left-sided numbness and slurred speech at 9 p.m. He decides to go to sleep and he says, I think I'm going to sleep it off. Maybe it'll be gone when I wake up in the morning. Next morning he wakes up at 8 and it's still there. What's your time of onset? Has that happened? You guys have seen that, right? I think I'll sleep it off. What's your time of onset here? 2100. TPA candidate?
No.
No way. But Angio Candidate, right? And that's if they get the imaging and they determine that, yeah, there's something that they can get in there and fix. Scenario number 8. Patient is normal all day, goes to sleep at 1 p.m. He wakes up at 6 p.m. and he's got left-sided weakness and slurred speech. Time of onset? 1300. TPA candidate? No. You missed it by 30 minutes, right? And you got to realize, even if you're there you get there at the 4-hour mark, you got 30 minutes left in that TPA window. Of course, you're still going to try to push for it and try to get everything possible, but it's going to be very difficult to get the patient to the hospital, get everything started, get the CTs and everything done, and then start TPA within 30 minutes. It's going to be a race for against time, but hey, it's worth the while, right? Because if not, these people can be left with potentially devastating, life-changing disability, so always worth it. But yeah, this guy, it's 5 hours when we get there, not a TPA candidate whatsoever. But angio is still possible, right? So don't forget. Scenario number 9, you got a patient who lives by himself. Daughter checks on him in the morning. She comes at 9 o'clock and she's there for an hour, leaves at 10. When she leaves, he's normal. She comes back at 12 to check on him, and now she knows that he's got left-sided weakness and slurred speech. What's the time of onset? 10 o'clock. TPA candidate? Absolutely. Okay, TPA candidate. And scenario number 10, patient lives by himself. Daughter checks on him at 9. When she leaves the house at 10, he's normal. She comes back at 3 o'clock to check on him, and now he has left-sided weakness and slurred speech. What's your time of onset here?
10.
10. This guy a TPA candidate? Nope.
No.
All right, 5 hours, right? So, not a TPA candidate. Last seen normal is 10 o'clock. So, he doesn't get TPA, could potentially get angio. So, in summary, remember, TPA candidate, it can be sometimes limiting just because it depends on how quickly they call us and how quickly we recognize it, okay? But they still may be a candidate for interventional treatment, okay? So remember that. It's within 24 hours and they've had symptoms going on for less than 24 hours, you want to still activate it as a stroke, okay? But you want to notify them, hey, it's been past 3 hours, it's been past 4.5 hours, but the guy's having a stroke, he may be an angio candidate. Getting accurate history and the time of onset, extremely important to be able to treat this patient, okay? If we mess up the timing, if we get a time that blows them past the 4.5 hour window, you could potentially miss an opportunity to give TPA and can lead to permanent disability. If we underestimate the time and it's been longer than 4.5 hours, we're putting that patient at high risk for developing intracranial hemorrhage. And that's why there's this time frame, because what they found is when you start giving it beyond that 3 hour window or the 4.5 hour window for certain candidates, the risk for bleeding goes up a lot higher, and that's why it's a very strict time frame. That's why it's very important that we get it, because not giving it versus giving it, it can be completely life-changing and potentially life-threatening to these patients. So very important that we're able to get that mark right. And then of course, remember your basics, okay? Always check a glucose in these patients. Hypoglycemia can very well cause stroke-like symptoms. Get an EKG on these patients, okay? You want to make sure there's no cardiac dysrhythmias or anything that's causing this patient to have, changes in their mentation. Get your IV access. That's going to help them because, all right, they don't have to stick and try to poke. But you don't want to waste time trying to get IV access because remember, it's a race against time. So if you don't see anything, you want to try to get moving as soon as you recognize this is a stroke that's within the TPA time frame. You want to get moving. You want to waste minimal time on the scene messing around. You only want to do any interventions that are going to be life-saving immediately. Otherwise, you want to try to get them to the hospital immediately, okay? So if you're able to get IV access on the move, that's ideal, but I wouldn't recommend hanging around for 15 to 20 minutes trying to get an IV on this person. Get going, okay? Because when you get to the ER, what's going to happen? Like 4 people are going to attack trying to get an IV. Better chance that they're going to get it a lot quicker. Don't forget our stroke scale. Document that in your documentation. That way you're showing that this patient is actually having a stroke. And then early notification of the facilities or Pulsera activation if you're using Pulsera, because that's what's going to really get the ball rolling. That's what's going to have that CT scanner ready for the patient. That's going to let the nurse know, hey, when they get here, we need to get that patient seen and get them to the CT scanner ASAP. So you want to do early notification. Give your patients the best chance of recovery. Early recognition, early notification, and minimal time wasting. Okay? Any questions? No? Okay. Well, happy Stroke Awareness Month then.